welcome to the Deep Dive. Today, we're getting into a really significant and frankly rapidly growing global health issue, how we manage the diabetic foot.
Yeah, it's a big one.
We've really dug into a major section of Rutherford's vascular surgery and endovascular therapy specifically, chapters 116 right through to 119. They're all under that main heading, the diabetic foot and its management.
Right.
So our mission here, if you like, is to try and pull out the key insights, the practical guidance from these chapters, almost like creating a concise instruction manual for vascular surgeons dealing with these issues day in, day out.
Absolutely. And the first thing that jumps out from the reading is just the sheer scale of this problem. We're talking hundreds of millions of people with diabetes worldwide.
Like growing fast.
And projected to grow dramatically. It's not just the personal cost, which is huge, but the burden on healthcare systems globally. So yeah, extracting that really practical, actionable knowledge for clinicians is key.
Okay, let's start unpacking it then. Chapter 116 kicks things off with the epidemiology, setting the stage. And the numbers, honestly, they're pretty staggering.
They really are. Something like 463 million people globally with diabetes back in 2020.
And the projection.
Projected to hit 700 million by 2045. That's a massive increase.
Wow. And the concentration. I think you mentioned China, India, the U.S.
That's right. Those three have the largest numbers currently. And it's sobering to think that even back in 2010, diabetes was already the 7th leading cause of death. It just shows how serious this is.
And the foot problems are a massive part of that morbidity and mortality.
Yeah.
Diabetes is, well, the leading cause of foot issues, right? Often leading to these diabetic foot ulcers, the DFUs.
Exactly. They come from that really nasty combination of nerve damage, neuropathy, poor blood flow, ischemia, and then being more susceptible to infection.
And the downstream effects are severe, things like amputation.
Yeah, most non-traumatic amputations, certainly in the US and Canada, are actually secondary to these DFUs. It's a statistic that really hammers home why effective management is so critical for us as vascular surgeons.
The prevalence figures were eye-opening too. Up to 15% of people with diabetes in the U.S. having active ulcers.
At any given time, yeah. And about 1 in 4 having a lifetime risk of developing one.
And infection complicates things further.
In about half of all DFUs, yeah. Which often, puts the patient on the path towards amputation.
And a cost. It's just huge, right?
Oh, absolutely. These DFUs, they're a major reason diabetic patients end up in the hospital. Drives up costs like crazy.
Right. What kind of numbers are we talking?
Well, the source material puts the average cost for treating one ulcer somewhere between, say, $8,000 and $17,000. It's substantial.
And if it leads to amputation?
Then it skyrockets. We're talking $40,000 to $60,000. These numbers really underscore why effective early intervention is so important, not just for the patient, but for the system, too.
And it often doesn't just end with one ulcer, does it? The recurrence rates are pretty grim.
They are dishearteningly high. Maybe 35% recurrence within a year, but up to 77% within 5 years.
Wow.
Yeah. So this cycle of ulceration really increases that amputation risk. It speaks volumes about the need for, really robust long-term patient education and sticking to offloading plans, which we know can be a real challenge in practice.
Definitely. And for those ulcers that just don't heal, the amputation risk jumps massively.
85%, yeah. And the mortality figures associated with this are crucial to grasp. Patients with DFUs face about a 10% annual mortality rate.
Which doubles with amputation.
Doubles to 20% if an amputation occurs. And if you look at major limb loss, the 5-year relative mortality rate is around 70%.
70%? That's shocking.
It truly is. It really puts into perspective the life-saving potential of effective limb preservation strategies.
Something else the chapter highlights, which is really troubling, are the disparities in outcomes.
Yeah, that's very well documented. Socioeconomic status, race, ethnicity, they all play a significant role, unfortunately.
Higher prevalence in certain groups.
Yes, African Americans, Hispanics, Native Americans have a higher prevalence of diabetes itself, and this translates into disproportionately higher rates of DFUs and subsequent amputations in these communities.
There was some specific data mentioned, wasn't there, from Medicare?
Yeah, 2008 Medicare data, it really laid it bare. While DFU incidence was concerning across the board, the amputation rates for African Americans and other minority groups were more than double that of white individuals.
And income level, too.
Even income level matters. Low-income neighborhoods saw nearly double the amputation rate compared to higher-income areas. It's likely a complex mix of factors, maybe later presentation, more severe comorbidities, unequal access to specialized care.
It definitely raises questions about equitable access.
It absolutely does. How do we ensure sure everyone gets the preventative care and the specialized management they need. It's a huge challenge.
Okay, so let's pivot to the pathophysiology. What's actually going wrong physiologically in the diabetic foot? Neuropathy is obviously a huge piece.
Fundamental. And the book breaks it down nicely into somatic and autonomic neuropathy.
Right. Somatic is the feeling part, loss of sensation.
Exactly. It's this insidious, slow, progressive loss of protective sensation in the feet. Patients literally lose the ability to feel things like pressure, pain, temperature.
Making them vulnerable to injuries they don't even notice.
Precisely. Stepping on something sharp, a burn from hot water, even just friction from shoes that don't fit quite right. Without that sensory feedback, these minor things can escalate quickly because they go undetected.
And it's not just sensation, there's motor neuropathy too.
Yes, and that's crucial as well. It leads to a muscle wasting, particularly the small intrinsic muscles of the foot. This creates an imbalance between the flexors and extensors,
Which causes structural changes.
it can weaken the anterior calf muscles, potentially leading to an equinus deformity limited ankle dorsiflexion. The end result is increased pressure, especially on the forefoot.
Which is where ulcers often pop up.
The most common site for these neurotropic ulcers, exactly, the data cited showed a 7-fold increased risk of ulceration just from isolated somatic neuropathy.
Okay, and autonomic neuropathy, what does that do?
That affects the involuntary functions. So in the foot, you often see reduced sweating. This leads to skin that's dry, brittle, and more prone to cracking and fissures, potential entry points for infection.
Okay.
Autonomic neuropathy also messes with microvascular regulation. So paradoxically, the foot might actually appear warm and well perfused. Even if there are underlying vascular problems, it can give a false sense of security.
Interesting. So building on the nerve damage, let's talk about the blood supply peripheral arterial disease, or a PAD.
Another major player. PAD contributes to roughly half of all DFUs and is implicated in, I think the figure was, a staggering 70% of mortality in diabetic patients.
Wow. And the pattern is different in diabetes, isn't it?
Well, the classic picture is disease below the knee, and for popliteal occlusive disease, you often see heavy calcification in those tibial arteries.
But femoral disease is similar to non-diabetics.
Yeah, the incidence there is pretty comparable, but it's that tibial artery involvement that's really characteristic.
Yeah.
And critically, that old idea that, microvascular disease means revascularization won't work, that's been disproven.
Good to know.
However, patients with diabetes do have a higher risk of disease in the really small digital arteries,
Yeah.
sometimes even if the main pedal pulses feel okay.
So revascularization is still often possible.
Absolutely. Tibial revascularization, especially if you can target the specific angiosome, the tissue territory supplied by the artery feeding the ulcer, is often feasible and absolutely vital for limb salvage.
Okay, next factor. Infection. The book mentioned the IDESA-PEDIS system for classification.
Yes, PEDIS stands for perfusion, extent size, depth tissue loss, infection, and sensation. It's a useful framework.
And when should we be thinking about getting wound cultures?
Definitely when there are clinical signs of infection, pus, increasing redness or warmth around the wound, maybe a bad smell, necrotic tissue.
But not just routinely swabbing clean-looking wounds.
No, that's generally discouraged. You'll likely just grow skin contaminants, which aren't the real problem, and it could lead to inappropriate antibiotic use.
Right.
When you do need a culture, getting a tissue sample, either surgically or by curettage from the wound base, is much more reliable than just a surface swab for finding the actual pathogens.
Makes sense. And there was a point about impaired antibiotic delivery.
Yeah, in diabetes, there can be elevated levels of certain adhesion molecules that actually impair blood flow at the skin level and can hinder how well antibiotics get to the site of infection. Another challenge.
And finally, the structure of the foot itself. Muscle and bone abnormalities.
Yeah, the biomechanics are often completely altered. Bony deformities like bunions, claw toes, issues with the MTP joints, they all create abnormal high-pressure spots.
Compounded by the neuropathy.
Exactly. The loss of protective sensation means these pressure points don't trigger pain, so the patient keeps walking on them, leading to breakdown. Add in muscle weakness from motor neuropathy, causing things like hammer toes, which further increases pressure on the metatarsal heads.
And then there's Charcot foot.
Right, Charcot changes that progressive destruction of bones and joints. It can lead to a total collapse of the midfoot arch, creating that classic rocker bottom shape, which is just a nightmare for pressure distribution and healing.
So pulling this together for the clinician. When a patient presents, history and physical exam are obviously key. What are the must-asks in the history?
You need the full picture. How's their diabetes control? How and when did the ulcers start? Any recent trauma? New shoes? Travel? How long has it been there? Has it changed? Crucially, any history of previous wounds or treatments, and of course, any systemic symptoms suggesting infection, fever, chills.
And documenting risk factors.
Absolutely. Document neuropathy status, signs of PAD, any visible bony deformities, previous interventions, bypasses, angioplasty, prior amputations, all essential context.
And the physical exam, what are the key components?
It needs to be systematic. Dermatologic. Look for that dry skin, hyperkeratosis or calluses indicating pressure, any subtle preulcerative signs like redness or blistering. Neurologic. Definitely assess for lost protective sensation, LOPS, using a monofilament. Vascular. Check pedal pulses. Look for signs of ischemia like hair loss, shiny skin, coolness, delayed capillary refill.
And musculoskeletal.
Look for those signs of motor neuropathy, intrinsic muscle atrophy, hammer toes. And be vigilant for Charcot. Is one foot unusually hot, swollen, red? Does it have that rocker bottom deformity? Remember, acute Charcot can really mimic other things like cellulitis, osteomyelitis, even DVT or gout, so you need a high index of suspicion.
Okay, so you found an ulcer. How do you evaluate and classify it properly?
Start with careful visual inspection. Is the tissue viable or necrotic? Is there drainage? What kind? Any odor? How much surrounding redness? Measure its dimensions. Note the exact location. Are there multiple ulcers?
Any other clues?
Well, if the location or appearance suggests venous insufficiency too, you'd pursue vascular testing. And then, the probe test. Gently probing the wound with a sterile, blunt probe.
What are you looking for?
Can you feel bone at the base? Probing to bone is a very strong indicator of underlying osteomyelitis. It also helps assess depth and checks for undermining or abscess tracts.
And classification systems. Wagner, UT, PETUS.
Those are mentioned, yes. Wagner is older and less descriptive. The University of Texas UT system adds depth, infection, and ischemia. PETUS we mentioned. But the chapter really emphasizes the WIFI classification as the most current and clinically validated one, advocated by the SVS.
WIFI wound, ischemia, foot infection.
Exactly. It provides a more nuanced risk stratification for limb loss.
What about imaging? When do X-rays or more advanced scans come in?
Plain X-rays are a good first step. They can show bony deformities, foreign bodies, sometimes soft tissue gas if there's a nasty infection.
And if things aren't healing or you suspect deeper issues?
That's when advanced imaging is useful. CT, MRI, labeled white blood cell scans, SPECT/CT, PE scans, they can help rule out osteomyelitis or deep abscesses when an ulcer isn't responding.
Which is best?
Well, PE2 and labeled WBC scans are technically very accurate for osteomyelitis, but MRI is often the go-to for many clinicians because it gives great detail on both bone and soft tissues and is more readily available.
Okay. So Chapter 117 then really drills down into managing these specific abnormalities. It hammers home again that DFUs are serious business.
Absolutely. They're not minor sores. They can quickly lead to infection, hospitalization, major surgery, and amputation in a significant percentage of cases, 10 to 50%, depending on severity and management.
And it revisits how diabetes affects the foot systemically.
Right. Neuropathy, limited joint mobility, deformity, Charcot, the angiopathy, it all comes together in the foot, typically causing ulcers at those high-pressure spots.
Yeah.
And it reinforces that concept of the impaired host, meaning the patient's own body can't respond normally. Neuropathy masks pain signals. The immune system is compromised, making infection more likely and harder to fight, and poor circulation hinders the delivery of nutrients and immune cells needed for repair.
Peripheral neuropathy gets another detailed look in this chapter.
It's central to everything. The chapter goes into the biochemical mechanisms, glycation end products, metabolic and vascular changes affecting the nerves. It differentiates the symptoms of small fiber neuropathy, that burning, tingling, electric pain, often assessed with temperature sensation,
Versus large fiber.
versus large fiber neuropathy, more numbness, cold feet, loss of vibration sense and reflexes, assessed with tuning forks, monofilaments, and it really emphasizes loss of protective sensation, or LOPS again.
Why is LOPS so critical?
Because it leads to patients not recognizing injuries when they happen. A simple puncture wound, which a person with normal sensation would immediately react to, can go unnoticed for days in someone with LOPS, allowing infection to set in deeply. This dramatically increases the risk of needing surgery or amputation. It also mentions the link between large fiber neuropathy and postural instability, increasing fall risk.
And the motor neuropathy's effect on foot structure is elaborated too.
Yes, the atrophy of those small intrinsic foot muscles throws off the balance between muscle groups. This leads to laxity in the joint capsules, bony malignment, joints starting to subluxate, and ultimately those deformities like hammer toes and bunions, hallux valgus that create pressure points. The loss of intrinsic muscle support also lets the metatarsal heads protrude downwards, making them really vulnerable to ulceration.
Chapter 117 also comes back to PAD, stressing again how vital perfusion is.
Absolutely critical for healing and saving the limb. It reiterates that standard ankle Dopplers, ABI, can be falsely reassuring in diabetics because of vessel calcification.
So toe pressures are better.
Toe pressures, TBI, and waveforms are generally more reliable. It also mentions newer technologies like hyperspectral imaging, HSI, and SPY fluorescence imaging for assessing perfusion, though it notes their role is still being fully defined, with some mixed results for HSI reported.
Key clinical points for surgeons managing PAD and infection.
A really important one. If there's significant infection, it generally needs surgical debridement before you revascularize to reduce the risk of infecting a new graft or stent.
And debriding ischemic tissue.
Generally, you want to hold off on aggressive debridement of an ischemic ulcer until after you've improved the blood flow, unless you strongly suspect infection underneath. For dry gangrene without obvious infection, delaying amputation, like a TMA, until after revascularization gives the best chance for healing at that level.
Good pearls there. And it reminds us again about the blunted signs of infection.
Yes, and the limitations of the Wagner classification, favoring the UT system for incorporating depth, infection, and ischemia.
Biomechanics gets its own focus too, highlighting the foot's complexity.
It's an incredibly complex structure, and all these diabetic complications really disrupt its normal function. Even an amputation can create new biomechanical stresses, increasing the risk of further problems down the line.
What kind of structural changes does it discuss?
Things like stiffening of soft tissues, the tendons, ligaments, joint capsules become less flexible. This limits the foot's range of motion and can lead to joints subluxing or dislocating.
Why does that happen?
It's thought to be a combination of that intrinsic muscle atrophy we talked about and the accumulation of advanced glycation end products, or AGEs, in the collagen, making tissues stiffer.
Leading to deformities.
Exactly. Things like hammer toes, equinus contracture at the ankle. These force compensatory changes in how the person walks, which usually means more pressure on the forefoot. Looking at where calluses form can give you real clues about these high pressure or high shear areas. And knowing if a deformity is reducible, semi-reducible, or fixed helps guide treatment.
Which leads nicely into offloading, a cornerstone of treatment.
Absolutely essential. Offloading just means reducing the pressure and shear forces on the ulcer. The chapter reviews the options.
Like?
Conservative methods range from simple padding and orthotic inserts to removable cast walkers or fracture boots, and then the gold standard for plantar ulcers, the total contact cast, or TCC.
Gold standard, but underused.
Yes. The TCC boasts very high healing rates, 70 to 90% in about 6 weeks, according to the text. But it requires specific training and resources, so it's often not readily available or utilized.
And other methods.
Things like walker boots, healing sandals, therapeutic shoes, they tend to be less effective, possibly because patients don't wear them as consistently as they should. Compliance is a big issue.
And if conservative offloading fails, or for specific deformities, surgery comes in.
Right. Surgical correction of the underlying biomechanical problem might be needed for ulcers that won't heal or keep coming back. The goal is to create a more balanced rectus's foot.
What kinds of procedures?
For deformities that are still somewhat flexible, reducible, or semi-reducible, soft tissue corrections like tendon lengthening can work well. Achilles tendon lengthening, for instance, can significantly drop forefoot pressure and has shown good results for healing and preventing recurrence. Releasing tight digital flexor tendons can help with claw toes.
And for fixed deformities.
Then you might need bony procedures. Things like shaving off bony prominences, exostectomies, or removing part of a joint, resectional arthroplasty. Often, you need a combination of tendon balancing and bone work. And even after surgery, some form of offloading is usually still needed during healing.
Okay, so turning to the ulcer itself, what are the broad treatment strategies?
Well, the chapter points out there isn't one single algorithm. You're often juggling multiple things: managing drainage, controlling swelling, tackling infection or biofilm, stimulating the wound bed to heal. The approach often depends on the clinician's background.
But the core principles remain.
Always. You need adequate blood flow, you need effective offloading, you need to control infection and biofilm, and you need to optimize the patient's overall health, nutrition, blood sugar control.
And antibiotics and dressings.
They support the process, optimize the environment, but they don't heal the wound directly. The key intervention for the wound bed itself is often regular, sharp debridement
Why debridement?
to remove dead tissue, reduce bacterial load, and essentially convert that chronic stalled wound back into an acute wound that has a better chance of progressing through the healing stages towards closure or coverage.
And amputation is also mentioned as a treatment strategy.
Yes, it's presented as a viable option in certain situations, particularly with extensive infection or ischemia that can't be salvaged, or for chronic non-healing wounds causing pain and dysfunction. The goal then becomes creating a functional stump, like a well-healed TMA that preserves the metatarsal parabola for better prosthetic fitting or shoe wear.
Charcot neuroarthropathy gets specific focus, too, as a really devastating complication.
Yeah, CNN is described as potentially catastrophic, driving up costs and hospital stays. The theory discussed is that neuropathy leads to bone demineralization and weakening, and then normal weight bearing causes microfractures, instability, joint dislocations, and progressive destruction.
Are there stages?
Yes, the Eichenholz classification outlines stages from zero early inflammation, warm, swollen foot, through fragmentation, coalescence, and finally consolidation, often with significant deformity like the rocker bottom foot.
Treatment.
Early recognition is paramount. Then strict non-weight-bearing immobilization, usually in a TCC, is the mainstay to allow the bone to stabilize. Once it's consolidated, lifelong custom bracing or footwear is usually needed. Surgical reconstruction is sometimes attempted for severe deformities but has very high complication rates.
The chapter revisits the impaired host concept, too. What's the significance there?
It explains why diabetic patients handle infections so poorly. They have a blunted inflammatory response both locally and systemically. Classic signs of infection readiness, warmth, pain, fever, high white count might be diminished or even absent, even with severe infections.
Why is that?
The leading theory involves leukocyte dysfunction. The white blood cells just don't work properly, partly due to the effects of high blood sugar. And interestingly, even chronic ulcers that don't look clinically infected often have very high levels of pro-inflammatory cytokines locally and are almost always colonized by complex polymicrobial biofilms.
Which leads right into the discussion on infection itself.
A major cause of hospitalization and amputation, as we've said. Diagnosis needs to be clinical based on signs and symptoms, not just a swab result. Remember, the impaired host presentation might be atypical.
How does infection usually start?
Usually through a break in the skin, an ulcer, a puncture wound. It rarely spreads through the bloodstream. It typically tracks along tissue planes, leading to deep abscesses and often involving the bone, osteomyelitis.
What kinds of bacteria?
Usually bacterial. Staph and strep are very common, but it can be polymicrobial, especially in chronic wounds. Treatment requires appropriate antibiotics, often IV initially, and usually aggressive surgical intervention draining abscesses, excising all infected and non-viable tissue, which might mean multiple trips to the OR and sometimes amputation.
And biofilm.
Its exact role in driving clinical infection is still debated, but we know biofilms are highly resistant to antibiotics. You really need physical disruption, thorough debridement to deal with them effectively.
Osteomyelitis gets specific attention. How common is it?
Surprisingly common. Maybe up to 20% in outpatients with DFIs, and potentially over 2/3 of hospitalized patients. Usually it's from direct spread from the ulcer. That positive probe-to-bone test is a strong clue.
Diagnosis.
Combination of clinical signs, X-ray changes, though these lag behind, and MRI is very sensitive for showing bone marrow edema and associated soft tissue changes. Bone biopsy with culture remains the definitive gold standard, though.
Any useful lab markers?
Yes, inflammatory markers like ESR and CRP can be helpful. The chapter suggests specific cutoffs like ESR 60 millimolars, CRP 7.9 milli-GDL that might help differentiate osteomyelitis from just soft tissue infection, and they're also useful for monitoring response to treatment after surgery. Reinfection after discharge is unfortunately common, so tracking these markers monthly post-op is recommended.
Okay, finally for chapter 117, prevention.
Yes, and this is where we can potentially make the biggest difference long-term. Vascular surgeons often see the highest risk patients, those who've already had an ulcer, amputation, or revascularization.
We prevent the first ulcer?
The evidence for cost-effective primary prevention in the general diabetic population isn't strong given the relatively low annual incidence, 2 to 7%. The real focus is on preventing recurrence in high-risk individuals. It requires a multidisciplinary approach. Addressing the underlying biomechanics, limited joint motion, deformities is key. But the mainstays are patient education, foot care, recognizing warning signs, regular podiatric evaluation, and crucially, properly prescribed therapeutic shoes and insoles.
Do therapeutic shoes really work?
The evidence suggests they do. Studies show they can reduce reulceration rates by 2 to 4-fold compared to patients just wearing their regular shoes. And a key tip, patients shouldn't go back to wearing the same shoes they had on when the previous ulcer developed.
Good practical advice. Okay, Chapter 118 broadens the scope a bit to chronic wounds of the extremities generally. Acknowledging surgeons often get consulted when things aren't healing.
Exactly. While DFUs are a major focus, this chapter covers principles applicable to other chronic extremity wounds vascular surgeons might manage. It briefly touches on classification, measurement, and wound bed preparation.
And debridement methods are revisited here too.
Yes, expanding beyond just sharp surgical debridement. It mentions chemical debridement with enzymatic agents, like collagenase, okay for some slaw, but not great for thicketusher. Larval therapy gets a brief nod. Ultrasound debridement is discussed too.
Is one method better?
The chapter concludes that generally, none of the alternative methods have proven superior to sharp surgical debridement in terms of outcomes, and they're often less cost-effective. They're typically reserved for when surgical debridement isn't feasible or ideal.
It also tackles bacterial colonization again.
Right. Highlighting that significant infection is common, 20–25% needing antibiotics in DFU trials. But the tricky part is deciding whether to treat bacteria in wounds that don't look clinically infected. Clinical exam alone is pretty insensitive for detecting high bacterial loads that might be impairing healing.
So routine cultures aren't the answer.
Still not recommended for uninfected wounds, as they're usually colonized anyway. But it does mention point-of-care fluorescence imaging, like Moleculite, as a technology that might help non-invasively identify wounds with high bacterial loads, 104 CFU, that could benefit from intervention. Accuracy is reportedly high.
What about antimicrobial dressings?
Use them judiciously. You have to balance killing microbes with potentially harming the cells needed for healing. Long-term iodine use fell out of favor for that reason, though newer slow-release formulations like cadexamer iodine aim to minimize toxicity. The bottom line is topical antimicrobials probably shouldn't be routine long-term, but might have a role for specific wounds with critically high bacterial levels.
Venous leg ulcers are mentioned briefly.
Yes, mainly referring to another chapter for details, but summarizing key points. Risk factors overlap with general venous disease. Reflux anywhere can cause ulcers. Duplex ultrasound identifies the source, and the pathophysiology involves inflammation and fibrosis leading to lipodermatosclerosis and eventual skin breakdown, often after minor trauma.
And DFUs get another mention, pointing back to Chapter 117 and the VSAP-MAS-VM guidelines.
Correct. Then it circles back again to pay in the diabetic foot, reinforcing key concepts. The typical below-knee tibial artery pattern, the fact that microvascular disease doesn't preclude successful revascularization, the vital role of both endo and open bypass for limb salvage. Indications are similar to non-diabetics: claudication, rest pain, tissue loss.
Assessing perfusion in diabetics.
Again, emphasizes ABI unreliability due to calcification, making TBI 0.6 for healing more useful. Also mentions PVR, PPG, TCPO2, and SPP with specific thresholds that predict healing likelihood.
Endo versus bypass.
Discusses endovascular challenges in tibial disease, but notes similar overall outcomes, maybe lower primary patency, but equivalent secondary patency and limb salvage compared to non-diabetics. Stresses the importance of runoff having at least one patent vessel below. Surgical bypass is highlighted as crucial, especially for larger wounds, potentially offering faster, more complete healing in some cases. Distal targets are feasible due to spared proximal vessels. Autogenous vein is always superior if available, giving similar results to non-diabetics. Alternative conduits are discussed if vein isn't adequate.
Okay. What about therapies to speed up healing?
Briefly mentions skin grafting and cellular or tissue-based products, CTPs, and then more on post-revascularization care for DFUs.
Like managing swelling.
Yes, using things like intermittent pneumatic compression, IPC, below the knee for popliteal level work, or pedal compression boots for more distal bypasses. Also stresses the need for close follow-up of dry gangrene or eschar after revascularization. Healing can occur underneath, trapping fluid and creating an infection risk, so frequent inspection and debridement might be needed.
Biophysical technologies like MPWT and HPO are covered too.
Right. Negative pressure wound therapy, NPWT mechanism, is explained. Suction removing exudate, stimulating granulation tissue, etc. It's widely used for complex wounds, but the chapter advises using it with specific goals, not as a cure-all. Notes randomized trials support its use in DFUs and post-surgical diabetic foot wounds.
And hyperbaric oxygen.
HBO's theory is boosting oxygen delivery to ischemic tissues. Protocols vary, costs are high, 15K, 40K. It cites a Canadian assessment suggesting it might be cost-effective compared to standard care for DFUs, but it remains somewhat controversial and resource-intensive.
Finally, Chapter 118 wraps up mentioning wound bed preparation.
Yes, referencing the importance of creating a healthy wound bed before using advanced therapies or grafts.
Which brings us neatly to the final chapter, 119, focusing on the team approach, specifically podiatric and vascular teams.
Crucial chapter. It defines podiatrists, their training, and scope, emphasizing how perfectly suited they are to work alongside vascular surgeons for comprehensive long-term care of these high-risk patients.
It gives some background on the podiatry profession.
It does, outlining the rigorous training in the U.S., the DPM degree, extensive residency, board certifications, ABPM for general podiatric medicine, ABFAS for foot and ankle surgery, with added qualifications available in areas like amputation prevention and wound care. It also touches on the UK model.
And their scope of practice, it varies, right?
Yes, by U.S. state, but generally includes full medical histories and physicals, ordering tests, diagnosing, and managing a broad range of medical conditions related to the foot and ankle, prescribing meds, hospital privileges, and performing surgery ranging from forefoot procedures and partial foot amputations in most states to even BKAs in some. They can also harvest local grafts and supervise HBO.
And in the UK.
A bit different structure, centrally regulated. Podiatric surgeons there have extensive training and are heavily involved in limb salvage, including complex reconstructions and amputations, working very closely with vascular teams. The key point is, wherever they practice, podiatrists and vascular surgeons naturally share these patients. Podiatrists often do the initial vascular screening leading to referrals, and they rely on vascular input for managing ischemia.
The chapter also makes a point of highlighting research contributions from podiatry.
Absolutely. Points to the influential work from the University of Texas group in the 90s developing the UT ulcer classification and the UT foot risk categories, which informed later international guidelines. Podiatrists were co-developers of the WII score and proposed key classifications for Charcot foot.
And their expertise in biomechanics.
Foundational. Really understanding how minor repetitive trauma in a numb foot with abnormal pressures leads to ulceration. It also notes significant publications by podiatrists in major medical journals and co-authorship on the global vascular guidelines.
This all builds the case for team-based care.
Exactly. Managing CLTI and diabetic foot complications is too complex for any one specialty alone. It needs an interdisciplinary approach. The chapter details how podiatric vascular collaborations have evolved, shared clinics, shared OR time, joint research.
Any formal collaborations mentioned?
Yes, the alliance formed between the APMA, American Podiatric Medical Association, and the SVS, Society for Vascular Surgery, back in 2009 was a landmark. It led to joint position statements, guidelines, educational courses, and numerous collaborative publications. The formation of the American Limb Preservation Society, ALPS, in 2020 is another example of this push towards integrated care.
How should these teams be structured?
The chapter outlines different models from basic teams to intermediate and comprehensive centers of excellence, depending on resources and complexity. It lists the core specialists needed at each level. The key is that the team should agree on goals based on established guidelines, like IWGDF, develop local pathways and protocols, and track their outcomes. These teams can significantly impact inpatient care, too.
And does team-based care actually improve outcomes?
The evidence strongly suggests it does. Given that most of the cost is inpatient stays, having a coordinated team approach, sometimes called a diabetic foot rapid response team, can streamline care and improve results. Multiple studies cited show significant reductions in major amputation rates after implementing multidisciplinary care models. There's also data showing the economic value of having podiatrists involved.
It mentions post-secondary amputation prevention.
Yes, preferring the term remission because the risk never truly goes away after an acute event resolves. The stats are sobering. 5-year mortality rivals some cancers, 50% DFU recurrence within a year, 50% risk of contralateral amputation within 2 years. Ongoing coordinated team care is vital.
And the chapter ends by circling back to prevention one last time.
Re-emphasizing patient education, proper footwear, and orthotics. It also mentions temperature monitoring at home as a potential tool for patients to self-detect early inflammation and prevent recurrence.
Okay, so that brings us to the end of this deep dive into a really dense but critical section of Rutherford's.
A lot to cover.
Definitely. So if we were to summarize the key takeaways for, the busy vascular surgeon listening, what stands out? I think first, it's crystal clear this is a multifactorial disease. You can't just focus on one aspect.
Absolutely. It demands a comprehensive, integrated, multidisciplinary approach. Neuropathy and ischemia are the twin pillars of pathology. You have to assess and manage both meticulously.
Right. And practical management hinges on things like proper, consistent offloading that came out again and again, and aggressive, appropriate debridement is non-negotiable for most ulcers.
Infection is a huge challenge, especially in these impaired hosts where the signs can be subtle. Vigilance and prompt, decisive action are key.
And finally, the importance of prevention, especially secondary prevention, and the proven value of collaborative care models, particularly integrating podiatric expertise with vascular surgery skills.
Yeah,
That seems essential for really moving the needle on amputation rates.
couldn't agree more.
So, considering, as we discussed, the immense personal suffering and the staggering financial burden of diabetic foot complications, it leaves us with a provocative thought for you, the listener. How can we, as a medical community, more effectively embed these principles, early identification, aggressive multimodal management, truly collaborative care into standard practice everywhere? How do we really make a dent in these devastating amputation rates and improve the long-term outcomes for our patients?
A critical question. We definitely encourage everyone to go back to these chapters in Rutherford's, look at the guidelines mentioned, and really think about how these principles apply in your own practice and system.